I'm Kate Shaw. I'm an OBGYN in the department here at the School of Medicine. I'm also a subspecialist in family planning, so I do a lot of work in abortion. So this is definitely one of my favorite topics. To do a broad overview, it's such a big topic and hard to get through everything, as you'll find out, so I'm just going to cover some highlights, but happy to answer questions as we go through. I have no financial disclosures. And just to give you a brief landscape of what we're going to look at today, we're going to talk about why contraception matters. So just a brief discussion about why it's important, and then a little bit about the history, because I think that's really interesting to see where we've been and where we're going, and then a little bit of some of the landmark contraceptive legislation that led us to where we are today. I'm going to highlight a couple of the contraceptive methods, mainly to contrast them to methods of the past, but definitely won't be able to cover every single method that there is, so we'll talk about those. Now, it's important with contraception to always remember contraception is about preventing pregnancy, but that doesn't exclude that you also want to think about preventing sexually transmitted infections. And so we're not talking about that today, but that's something just to remember when you think about contraception. So why does it matter? Contraception is about empowering people to decide when and if they want to be pregnant. It's about sex without reproduction, and it's about preventing, planning, and spacing pregnancies to what makes sense for women's lives. The average U.S. person wants 2 children, so that means 20 to 30 years of their life they're trying not to get pregnant. 99% of sexually active people have used contraception, and some use it for non-contraceptive reasons, and so that's an important consideration. So in the U.S., in 2011, which is the most recent data we have, about half of pregnancies were unintended, so 45% of the 6 million pregnancies. Now, some of those will go on to be unintended or mistimed births or miscarriages, and some will be an induced abortion. So why does unintended pregnancy matter? Well, one, we know that even if you do go on to have an unintended mistimed birth, there's more risk associated with that pregnancy. So there's a higher risk that women don't have prenatal care during their pregnancy, which increases the risk for that mother and future baby, higher risk of prematurity, and also additional unintended effects of financial burden or other impacts on school, job, and other life trajectories. So just thinking about the history, as far back as 1500 BC, contraception was described. So there's descriptions of acacia leaves, gum, honey, and lint placed in the vagina to prevent pregnancy. And then in the 600s, we start to see people taking substances by mouth to try to prevent pregnancy and continue to think about consciously avoiding pregnancy. So through the coitus interruptus or the withdrawal method, or again, taking substances to try to interrupt or prevent a pregnancy. And then in the 700s, pessaries are described. And these were often originally described in the use of camels. So in nomadic cultures that had camels, they would place stones into the vaginas or uteruses of the camels to prevent pregnancy, because during a long journey you wouldn't want your camel to get pregnant. And so then this was applied also to women, and we see that described, different substances in the vagina. So these are some old pessaries that were used for contraception, whether in the uterus, in the vagina, or in the to prevent pregnancy specifically. Pessaries have other uses too that we know about, but these are some old ones that were used for pregnancy. So more modern day, so starting in the 1800s, there was a feminist movement that talked about this idea of voluntary motherhood, so again, deciding when and if women wanted to be pregnant. And then at the same time, there was a social purity movement that came about that said contraception was immoral and promoted prostitution and venereal disease. So immediately these two movements are opposed to each other. We see the Comstock laws come out of the purity movement, which was basically an act that criminalized the use of the postal system to send anything related to sex, contraception, or any other abortifacients, obscenity, etc. And so it made it a crime to send anything like that in the mail. And this was really an effort to prevent that contraception. It was the first attempt at repeal was soon after its first initiation. And then in the 1914s, we started to get a little bit more traction on the contraception movement. So a few leaders, including Margaret Sanger, who you may know the name of, in New York City, got together and said that there was a concern about the hardship of childbirth and unsafe abortion that they were seeing in New York City, and they were trying to increase access to contraception for women. This is where the Planned Parenthood clinics came out of, and there was a lot of work done to increase awareness and education for people about what the contraception options were. And then in the 30s, there were a few other important things that kind of led the way to the development of contraception. One of the key ones was that the Pope at that time stated that if a married couple had been sterilized, so through a hysterectomy, for example, and couldn't get pregnant, that them having the act of sex was not a sin, because, even though they would not be able to be pregnant, and was sex without reproduction. And this kind of was an important piece in the development of the pill, which we'll talk about. In that same decade, there was a correction. Previously, the rhythm method actually had people saying that the fertile period was the non-fertile period, and so it was almost like people were using the rhythm method exactly wrong. And so that was another important correction as we learned more about physiology. So Margaret Sanger and Catherine McCormick, who you may notice Dr. Subak's chair is named after because she was in this area, got together. She was a philanthropist and Margaret Sanger was an activist, and they elicited Gregory Pincus, who was a scientist who had been working in various places, to develop the pill. And so they funded him to develop the pill. And in the 50s, he discovered an important component of the pill, and around the same time, those Comstock laws are finally repealed, so many, many years later. And then finally, in 1960, we see the first birth control pill become available. So this isn't that long ago that we really see this is the start of modern-day contraception. Now, what does that mean? So you make a contraception, but who has access to it? What are the laws around that? Well, apparently in the 60s, it was illegal to do this, to provide married people with information about birth control. And so in Connecticut, as well as several other states, this was illegal. And two physicians, one of whom worked at Planned Parenthood at that time, were arrested for providing information to a married woman about contraception. They appealed this case to the Supreme Court, and they heard it. And they said that they found that this concerned a relationship lying within the zone of privacy created by several fundamental constitutional guarantees. And once this was decided by the court, they established this right to privacy. So basically, they said, would we allow the police to search the sacred precincts of marital bedrooms for telltale signs of contraceptions? And the very idea of this was repulsive because of this idea of the right to privacy. So this right to privacy becomes a very important landmark in many of the things that we see in women's health today. The pill gained a lot of traction and publicity. This is the front cover of the Time magazine in 1967. A lot of women started using the pill, again, available to married women. And then it wasn't until 1972, so fairly recently, that law was challenged. So William Baird was a professor speaking at Boston University, and he spoke to a group of both married and unmarried women about contraception, and he was sued. And it was based on a Massachusetts law that allowed the sale of contraception only to married people. And so because he had talked about this with unmarried people, he was being charged. And this went to the Supreme Court, and they upheld that the right to privacy that was established previously also extended to unmarried people. And so this was big. So now everybody has the right to privacy and the right to access to information and to birth control. So big deal. So that's kind of where we are today. Now, more recently, we have the ACA, which established that contraception methods, all of them, should be available at no cost to women. And so people in those plans, which are the majority of plans, are supposed to have access to contraception. So a very different landscape that we're in now. There's some other differences, too. So this is kind of what the landscape looks like today. There's a lot of different contraceptive methods available. In fact, it can be a little bit overwhelming for people to choose what's right for them because there are so many different options. So you're often basing it on what your friend was on or what you heard about from someone else, and so we kind of don't always utilize all the different methods. There's a lot of different reasons people use different methods, and we'll talk about some of them. But in 1960, it was a different picture. So we got the pill. That was a big win, which is this little bottle on the left. We had an IUD on the market. That's the little one on the bottom. There was a diaphragm, which had been available since the 1800s, and then condoms. So not a lot of options, but a lot more options than there had been before. So the pills of yesterday are very different from the pills of today, and I want to spend some time contrasting them because I think it's important in understanding the risks and use of birth control. So this first pill was, again, revolutionary, right? So you found a combination of hormones that could prevent pregnancy. It was about 3 times the dose of estrogen and progestin, the two components of the pill, compared to modern-day methods. So a very different animal than we have today. pretty quickly, they were trying to come up with ways to better help people to remember to take them or comply with them, because this is a pill you have to take every day. And so they came up with some different technologies. You see this pack here was one of the first, and then not soon after, the dial pack, which is very similar to some of the dispensing mechanisms we see today, was developed. They were also quickly adjusting that dose of hormone because the side effects were pretty severe with that high dose of estrogen and progestin. And so pretty quickly they started to describe a decreasing dose. And even this decreased dose that came out early in the 60s is still much, much higher than the doses we have today. So the pills of today, these are all the combined hormonal contraceptives. So they contain two different hormones, an estrogen and a progestin. And we've now today lowered the dose of the hormone, so they're much better tolerated. There's fewer side effects. There's newer progestins, so there's many different options. So there's hundreds of different types of pills, both brands and doses and types of different hormones. And that's really affected the side effects and improved the overall profile and really helped us individualize. So some women do better on one type of pill than another, and that's a lot to do with the different types of hormones in them. In addition, we have new delivery systems. So if the pill of every day isn't right for somebody, there's also a vaginal ring that delivers the same hormones and a patch. And so we have new options for delivering this type of contraception. So what does this type of contraception mean? So the combined hormonal contraceptives contain, again, the estrogen and progestin, and they all work the same way. So they suppress ovulation, they thicken the cervical mucus, which helps prevent fertilization, and they decrease tubal motility. They're pretty effective when taken correctly, and the side effects are most commonly irregular bleeding, headache, breast tenderness, and mood changes. This is one of the more common ones we also use for non-contraceptive benefits because they provide such good menstrual regulation. There's a few reasons we don't use them in women. So estrogen-containing birth controls are the ones that we pay attention to a little bit more because we know people that are increased risk of vascular disease or stroke can have an increased risks when we add estrogen. That's the pill. So we've come a long way, but it's still the pill. It's still something you have to take every day. So there's some other options. So another one I want to highlight is the IUD, because this is, again, one of the methods that's the most effective. And we see some of the IUDs of the past influencing the IUDs of today. So IUDs of yesterday, the first one was this gynecoil that I showed earlier. And this was developed, this part here that you see here, this stem, actually protruded out of the cervix and could be palpated in the vagina. So if you imagine something very sharp or firm sticking out, it wasn't as popular during intercourse. And so this was quickly replaced by some other ones that had this softer string that hung into the vagina and was much more flexible. These two were actually very popular and very well tolerated. And so the IUD started gaining some popularity. Again, mostly amongst married women. These weren't typically used in unmarried women at the time. And then in the 70s, we got the Dalcon Shield. Now this one just ruined it for everybody. It really actually did cause problems and really ruined the reputation of the other IUDs, so much so that these top two, the Lippy's Loop and the Safety Coil, were taken off the market because they were so unpopular because of the concerns with the Dalcon Shield. And it was associated with an increased risk of infection, and it was associated with infertility because of those infections. And so we did see that quickly get off the market. Now, the Copper 7 came about around the same time that the Dalcon Shield was pulled, but didn't really gain a lot of traction because of the awful reputation that the Dalcon Shield left everyone with. So here's a little chart of what that looked like. So you can see in the 80s, we still had about 7% of people using them, but quickly dropped down to almost nobody using the IUDs. And then the new IUDs, which I'll talk about, the copper and the leave-in adjustable IUDs, came on the market, and we start seeing this rise in IUD use. And why is that? So the IUDs of today are much safer. So they have a lot of myths that I'll dispel. But basically, just to compare these two types. So the non-hormonal, the Paragard, is the brand available in the US. And that's a copper IUD. So you can see the picture here. It's a plastic T with copper wire around it. And the copper serves to reduce sperm motility, kind of like a spermicide, and prevent fertilization. It's very effective and good for 10 to 12 years, and it's non-hormonal. So for people that want a non-hormonal method, this is a really great option. It's very effective. Requires an insertion, but then you don't have to think about it again. So these are our forgettable contraceptives. The hormonal IUDs came out a little bit later, in the 2002, and they're a similar design. They're a plastic T with a hormonal reservoir. So you see at the stem of the T there, you see a little reservoir, and that's where the hormone is released. There's several different brands. and doses. So there's 3 devices made by one company that have 3 different doses, and another brand from another company that has a similar dose. These are good for 3 to 7 years, depending on the dose of the hormone, and are very effective. They work to inhibit fertilization by thickening the cervical mucus and thin the endometrium. And so one of the side effects that people see with this is decreased menstrual bleeding, and it's actually one of the indicated approvals for the use of the IUD. So for women with heavy bleeding, even without wanting contraception, it's a great option.
Would a doctor not recommend if you want to have the non-hormonal, but only for 3 to 5 years? Would they stay with that, or would they just...
That's a great question and a common one. So this is the kind of how long it's good for, but in no way is that how long you have to keep it in. So we know from looking at what's cost effective. So is it cost, because these cost more up front. So is it worth putting one in if you're only going to use it for a year or 2, even if the device is actually good for 10 or 12? And it's cost effective because we know contraception in general saves $2 for every $1 that you spend on it, and even with the IUDs. So if you're going to use an IUD even for a year, it's cost effective because of how good it is at preventing unintended pregnancy.
And they're free anyways for...
Yeah, so they're covered now under the Affordable Care Act or through California Medicaid programs, like the Family Pack program. So, few side effects. So the big one is non-hormonal. It doesn't affect periods positively, and in about 1/3 of women, it can make periods heavier. So that's the most common thing. So for women that have heavy periods, it's not usually the first one we go for unless they're really motivated to not have hormones. The hormone level in this is so low that you don't have the same side effects that you would with other birth controls because the hormone's just locally concentrated in your uterus, and so people have very few side effects. But some of the things that we hear most are the decreased or absent periods. So a lot of women want that, and so they pick this IUD because of that, but some people don't want to lose their period. It's very important for them to continue to cycle every month, culturally or emotionally, and so they want to keep doing that. So that could be a negative side effect if you're not prepared for it. In addition, some women do see a little bit of acne, especially if they're switching from a hormonal birth control, which we know helps acne, and then a slightly increased risk of ovarian cysts over baseline in the clinical trials. So thinking about the myths of the IUD, so the IUDs of today, contrasting them to the IUDs of the past, the IUDs of today don't cause pelvic inflammatory disease and don't cause infertility. The myth that they should only be used in women that have given birth is a common one, and that's not true. So women and teenagers, anyone can use this method. And it doesn't have to be only in people with one sexual partner. So again, the way that modern IUDs are used are very different than the ones of the past and doesn't require that you've given birth or have only one partner because it doesn't increase your risk of infection. Now, the other long-acting method, which is an important forgettable contraception, is the implant. So to contrast this to an implant of the past, some of you may have heard of the Norplant. This was available in the 90s, and it was 6 rods of levonorgestrel, which is one of the progestins, and it was inserted into the arm, so in 6 different rods. This was a very popular method in that it was something you could get and then not think about. It didn't require a daily pill. It was something that was just one and done, and you could forget about it. The disadvantage was it caused some irregular bleeding and some of the other progestin-related side effects like headaches or mood changes. And people felt like they hadn't been warned adequately when they got the method, and so there were a lot of lawsuits that ultimately resulted in the Norplant being pulled off the market, or the company deciding it wasn't worth it anymore. But now we have this new implant, originally the Implanon, renamed the Nexplanon, but has been available since the mid-2000s. And it has 1 rod, and so you can imagine this is a lot easier to get inserted and a lot easier to remove. And that was another problem with the Norplant, was that removal was very difficult. You can imagine trying to get 6 rods out. And so this method is very popular. It's good for 3 years, probably longer based on some newer data. It's very effective, touted to be one of the most effective forms of birth control. So once it's under your skin, it can't fall out the same way an IUD could fall out. And so that's proposed to be one of the mechanisms. And it causes irregular bleeding, headaches, and mood changes, similar to the other progestin-only methods. So those are just a few of the methods, and I spent some time talking about those. So if you imagine you go to your doctor, your provider, and you have 15 minutes to decide on what you're going to do for birth control. for me to go through all of these methods in detail about what the side effects are and what it means to use it is pretty difficult and really overwhelming for patients. And so oftentimes they'll just choose the one that they've heard of before and maybe not the one that's right for them. We do have a lot more methods now, though. And so what we have seen is compared to the 80s, when about nearly 60% of pregnancies were unintended, we have seen this number slowly declining with more and more contraceptions available. And then most recently, between the last two data points, we saw this big drop. So we wondered, why did that happen? Why are all of a sudden more people not getting pregnant? What we didn't see was an increase in the number of births. So we don't think it's that people were just deciding to do different things and were more planning to have a birth. But we think it's related to the effectiveness of the contraception. So if you think about perfect use, meaning if you did everything just right, how well does your birth control work, versus how does it actually work in your real life when you have a lot of things going on, maybe you forget your pill pack, whatever happens, how does the difference happen? And so this was from the New York Times, which did this for every single contraceptive method. So if you have free time to peruse this, it's very interesting. But just to highlight the ones I talked about, so if you look at the pill on the left, you can see in that first year, it's about 92% effective. So only 8% of women using that method in the first year will become pregnant. But over time, because of the requirement that you take something every day, more and more people get pregnant. And so 61 out of 100 will become pregnant after 10 years of typical use, meaning real world, because more than half of people we know actually forget more than 3 pills in a month, and that makes it ineffective. And so people aren't really using it right. Now compare that to an implant, which I said you get it placed, and then you have to actually do something to get it removed. So the likelihood that if you forget something, you're going to get pregnant is low. You can see there's no difference in typical versus perfect use because it's kind of foolproof. And we know that the reason that most women get pregnant when they don't want to is that they're not using, or they're using their birth control incorrectly. It's not actually usually that they're using it perfectly and the contraceptive method failed. So that's only about 5% of unintended pregnancies. The majority are inconsistent, incorrect use, or non-use. So here's an example. This is not correct use. If you don't know the pill pack, you take one every day and you go through. And so people kind of have different versions, and a lot of that's our responsibility as healthcare providers to educate them correctly. And so one of the movements is to, instead of saying, here's the 20 methods you could choose from today, let's talk about them in a different way. And so this is the new way to talk about them, which is to present the different birth controls as far as what's most effective, and that's how they're kind of organized here. So that top layer is those forgettable contraceptives or permanent contraceptives being the most effective, and then as you go down, you can see them get less effective. You can also see that the further you go down, the more user requirement and thus user error is possible. So if you have to do something every time you have sex, you're more likely to mess it up than if you have to do something once a month. If you have to do something every day, you're more likely to mess it up than if you have to do something once every 3 months. And so presenting the options in this way helps people to make a choice that's right for them. And so why do we see that drop? So when we look at what people are actually using, we see this increase in the IUD and implant. So those long-acting methods that have kind of that foolproof, the forgettable contraceptive profile. Just going to have a couple slides, but one of the common myths that I want to dispel is that birth control, you need a flush out period before you get pregnant, that there's something birth control does to make your fertility go down, or that you're less likely to get pregnant right away, and so you should stop birth control a year before you actually want to be pregnant. And that's not actually true. So if we compare people using nothing to using the different methods, the only one that we know may delay pregnancy by a few months is the injection, and that's not in all women, but in some women. So you should use birth control until you would like to be pregnant, is the takeaway. So contraception.
Isn't there some iron depletion problem though that you should be supplementing?
Because of birth control?
With hormones, like they reduce your iron.
No, actually we see the opposite. So because of the menstrual regulation, people's iron levels often go up on birth control. It's like one of the treatments we use for chronic blood loss anemia. Yeah. But prenatal vitamins are always a good idea when you're trying to be pregnant, yeah. So, contraception works well when it's used correctly and consistently. Everyone's different what works for them, and forgettable works better in the real world.